stragglers or sneak in.
That's fine.
It's a small room, but still remember to project your voice because this fan is running. Okay.
All right. Okay. So, first off, thank you all for coming. And if you have any questions at all during the presentation that you need clarification on, or if you're confused on how I explain something, please raise your hand. I'll be more than happy to answer them. So for those of you that do not know, my name is Allyson Badman. And so without further ado, let's get a quick show of hands. How many people here have experienced a sports-related injury? Yeah, not fun, is it? And you're stuck on the sideline. Imagine if you were sidelined for 9 months. How would that affect your high school career, your college, your life in general, anything, your future plans, period, anything that you wanted to do? As an athlete, one of my worst fears is having an injury that puts me out of play. I've been, as all of you have, I play sports and I've been injured before, and to be honest, it's something I actually, I cannot handle sitting on the sideline, watching my teammates out there playing for me and not being able to go out there. It's something that I just can't even handle, especially I can't even fathom being out for 9 months. So, and as a soccer player, one of my biggest fears is tearing my ACL. And so with this project, I decided to choose this as my topic so that I could look into it and learn a little bit more about the mechanisms of it and understand how I can prevent and limit my risk of this type of injury that I'm deathly afraid of. And that way I can also understand just how it works, how I can prevent it. And also my future plans, I plan to become an orthopedic surgeon, in which case I will be dealing with a lot of things in this field and in aspects of what I researched. And overall, my research was awesome. It really helped me a lot get to see what I will be dealing with in my future school and career, and I really enjoyed it. I didn't have any problems for the most part finding my information. The most difficult part about my research, I thought, was understanding all of the medical texts and learning how to read the new formats of in the APA and just figuring out the formatting for everything and learning how to read it. So without further ado, let's get this show on the road. First off, a quick handout I want to distribute for everyone. So this is just a diagram of the human knee because we're going to be throwing around a couple medical terms here, and it can be kind of confusing trying to keep them all straight if you don't have a background in them. So highlighted is just the anterior cruciate ligament, which we will go over in a second. And there's just some quick definitions for this. Okay. So, looking at this chart I have up here, what jumps out to you guys? Just at a quick glance, what's one of the first things that anyone notices? Or anything stand out really?
How high girls soccer is compared to all the others, and girls basketball.
Right. Yes, it is extremely higher. There's, as you can see, the girls' athletics is almost double that of what males is. And so, how many people? Any guesses, really quick? How many people tear their ACL per year in the United States? Any guesses?
Shy girls?
49.
No, boys and girls.
Yeah.
Is it year 49? 150.
No. In the United States, an estimated 200,000 anterior cruciate ligament tears are sustained annually, and that's according to the Academy of Orthopedic Surgeons. So yes, and as you see in the graph, a general idea, the majority of these tears are suffered by women. Okay. So here we've got a diagram of the knee, very similar to the one that I handed out. This is your anterior cruciate ligament, and well, the knee is basically, it's a complex joint. It's a hinge joint, so that means that unlike your shoulder, where you can move it in all sorts of different planes, and your hip, you can swing around in a circle, your knee really only bends through 2 planes and basically in one direction, just like a door, like a hinge on a door. And so main components that make up your knee, we have your femur, which is your thigh bone, that's the giant bone up here. You also have your tibia and your fibula, which are your shin bones. And the tibia is the main one we're going to be talking about today. The fibula is still important, but the tibia is more related to what we'll be discussing. We also have your LCL, or your lateral collateral ligament, and the LCL just serves to help keep the knee stable from side to side motion and to keep it from twisting around like in a circle. And your MCL, which is your medial collateral ligament, is basically the same as the LCL, just on the inside of your knee. And then there's also the posterior cruciate ligament, which is attached between your femur and your tibia, and that just keeps that's just stability to keep your knee from sliding around. And last but not least, we have your meniscus and your anterior cruciate ligament. The meniscus is basically, it's like a cartilage kind of material, and it's padding and like a shock absorber for like when you jump or land, or even as you're walking or running. It keeps your two bones from grinding against each other, which is extremely painful. And so your anterior cruciate ligament, which is the most commonly injured ligament in the body, and what the ACL does is it connects the femur to the tibia in the knee and limits the rotation of the knee side to side. And without the ACL, there would be nothing to prevent your shin basically from shooting forward out from under your knee. So whenever you would turn or anything, there would be nothing there to keep your shin connected to your leg, really. Okay. So this chart here is courtesy of the British Association for Sport and Exercise Medicine, and it represents the occurrence of ACL injury based on a percentage of all injuries in sports, like just all injuries in general. And so one thing I want to point out is note in the top couple of sports, 4 of the top 5 are women's sports. And we have women's basketball, women's gymnastics, women's lacrosse, women's soccer, and then men's spring football. So keep that in mind. We're going to come back to this later. Here we have ACL injury represented as a rate per every 1,000 exposures. And an exposure is just like a practice or a game or any time that someone is as performing an activity in which they could injure their ACL. So once again, notice that 3 of the top 5 are women's sports. Women's gymnastics, women's soccer, and women's basketball, and women's lacrosse is also close at number 6. So keep that in mind. We will come back to this. All right, causes of an anterior cruciate ligament injury. An ACL tear, often it's very rare that you can tear your ACL and not have any other damage to your knee occur, because the ACL is a ligament, so it requires a lot of force to tear it. And an ACL tear, as I said before, can happen with, most commonly, it's a fast direction change, so that would be like your pivoting or your quick stop-start kind of thing. Deceleration, like quick stopping from a sprint, you can tear your ACL. Also, incorrect landing, say in basketball, if you go up for a jump and you land wrong, you can tear your ACL. As well as in sports such as football or rugby, you can have direct collisions that shove the tibia out from under the fibia, or basically any kind of motion where one half of your leg is jarred in the opposite direction of the other half, it will tear your ACL, because that's the job of the ACL, to stop that from happening, and overload of that will tear it. So, yep, and so quick question. What % of the injuries to the ACL are sustained through non-contact? Any questions? Non-contact. 10.
40%.
40%? No. 70%. That is 140,000 out of the total 200,000 ACL injuries occur through non-contact. So that's just I thought that was baffling. But why now in the top 5, going back to the other 2 charts we had, why in the top 5 for each? Why, like, they're the same sports and they're played by the same rules, so why are the women's sports so much higher than men when it's the same type of movement, the same exposure, it's the same, so that was my main question, and leads to my thesis. Advancement in medical and rehabilitation techniques have improved the diagnosis, treatment, and recovery of cruciate ligament injuries. However, there is a great disparity between male and female susceptibility to cruciate ligament injury due to structural, biomechanical, and neuromuscular factors. So I just have a couple more pictures for you guys. This is your normal ACL. When your knee is straightened, it just is showing how it keeps your knee in line, keeps your bones from sliding around. And then when your knee is bent on the farther away, that's what it just goes taut to keep your shin from popping out. And when it's torn, excuse me, if your knee is straightened too far and your shin is pushed out, that's what it would look like. And then that's just the motion, or you can also have your twisting motion on the side. So yeah, those are some visuals. Okay, so.
Could we say, ouch?
Yeah, very painful, very painful. So, as I said before, women are statistically exhibit higher rate of ACL tears than men, as shown in the graphs before. One possible contributor to this is the post-pubescent structure of females compared to males. Post-pubescent meaning after puberty. Medical professionals also hypothesize that the elasticity and the strength of the ACL is determined by the amount of circulating hormones. And so as you go through puberty, as you all know, males and females are very different after puberty, and that is because of the hormones that more hormones are produced and in different quantities are all shifted around. So 2 hormones that are found primarily in women are estrogen and relaxin. And these hormones basically function to keep the muscles, the ligaments, and the tendons very loose and very flexible, which has its evolutionary benefits, for example, in childbirth and so on. And then testosterone is a hormone that is found primarily in males in higher quantities, and testosterone contributes to the strength and makes ligaments and tendons and so on more rigid than that of females. And so, essentially, what happens is the University of Maryland did a study where they analyzed the effects of these higher quantities of hormones in females and their strength and how that contributes to the strength of their ACLs. And what they found was in males and females performing the same activities, they found that the females, when the same force was applied to both the males and the females were more likely to tear their ACL, which sounds strange because you would think if it was more flexible, they would be less likely. However, what happened was with the more added flexibility, the muscles were looser as well, and when the muscles were more loose, they weren't strong enough to keep the knee from moving in such a way that the ACL was torn. So that flexibility didn't provide stability. Whereas the males who had the testosterone, which was more rigid and made them stronger, for lack of a better word, were less likely because the muscles surrounding the ligaments themselves made it less likely for them to wobble or be pushed. Like the same force experienced on a man would just cause them to fall over, say, whereas a woman, it would cause her whole leg to bend out, if that makes sense. So then also the University of Maryland looked into, in that same study, they looked into different times of the month in the women's menstrual cycle and how that could play a part in the ACL risk. So this is just a graph of the levels of estrogen and relaxin that are found in the females during their menstrual cycle. And as you can see at different times, those levels, they spike. And their hypothesis in this was that at different times of the month, women were more susceptible to tearing their ACL than at other times of the month. And while this study itself does show that, yes, there are an abundance of hormones at this time, there have been other studies looked into by the University of Colorado that looked into a very similar approach, and they were inconclusive. They did not show this result. So this has been not proven, but it's an idea that is still being researched, and it is backed up by some studies, whereas other studies show no correlation. Okay, so this is a picture of the leg. This is the back of the leg, so this would be your gluteus maximus, which is your butt muscle. We also have your hamstrings here, and then your quads here. Okay, so the quadriceps function to extend or straighten your knee, and your hamstrings function to flex it or bend it. And then the gluteus maximus and the hip flexors are just all support, and they aid in flexing the hip, flexing the knee, moving the leg, and so on. So females exhibit, according to the Houston Clinic, females exhibit an imbalance in strength ratio between the quads and the hamstrings. And this imbalance leads to a tendency in female athletes to utilize the quadriceps more when decelerating, whereas male athletes were found to utilize their hamstrings more. And so what happens is as the females are decelerating, they're creating like this kind of a motion, and as they use their quadriceps, they're pushing down, which is, I mean, if like I can feel it right now, it's more strain on your knee, and it creates a scenario where it's more likely to slide your shin out, or if your foot gets caught in the turf or the grass, or it's just a situation that it leads to further situations that make you more likely to sustain a knee injury, whereas males were found to decrease more like this, which provided more stability for their knees. And then, so one possible difference for this imbalance of strength ratio and the difference in biomechanics is the structure of female hips. So this is your subpubic angle, this right here, and it's between your legs. And this is the pelvis, by the way, this is the human pelvis. And what happens basically is females have a wider hips for evolutionary purposes in childbirth, and just for females have evolved to have wider hips. So this is the male pelvis, and this is the female pelvis, number 2. And as you can see, the subpubic angle of the male, they're always 90 degrees or less, a very acute angle, which the subpubic angle then, when it's more acute, it leads to legs that are straight, and that's why males are more straight, whereas females are curvier. Because with the females having a larger subpubic angle, their legs are more like this, sort of, and that's, females are curvier than men. So when their legs are at this angle, it creates something that is called knee valgus. So before we get into knee valgus totally, we need to talk about the Q angle. The Q angle is also known as the quadriceps angle, and basically it's the angle that is formed when the femur meets the tibia. And so this is the females, and as you can see, it is way larger than the males, which is over here. And they measure the Q angle with a goniometer, which basically shows how the angle of which your leg is bent in. And it's kind of hard to explain because you don't usually think of your legs being bent in, but if you actually, if you take away the muscle and you look at the bones are kind of at a triangular sort of angle. And so when you have this occurring, what happens is if a male and female experience the same twisting motion, because the female's leg is already tilted in like that, and it's already kind of a weird angle for the, it's just physics and force, and it's a weird angle to be at with it's more stress on the knee. If a male and female would be to exhibit the same twisting force, a male's ACL might only be sprained or stretched, whereas the female could completely tear her ACL and completely destroy the ligament. Also, aside from the Q angle, or in addition to it, a possible contributor to the difference in biomechanics is the intercondylar notch, which is located on the femur. So this is your femur, and then as your femur at the end of it, the bone kind of goes like this. There's like a little notch there. And this notch provides attachment for your PCL and your ACL, and it's an attachment so that your tibia and your shin can basically connect to your femur. And so the width of your intercondylar notch is different in males than females. Females have a much smaller notch than males do. And so what this leads to is males, when they twist or they turn or they stop suddenly or in a movement, their ACL has more room to move around and say they do stop suddenly, their ACL has that room to whoa, and it can be jostled. Whereas the females have much less room, so they experience that that jolt, that shock, and it has no room to move, and the force is just completely channeled into the ACL and causes it to rupture. This, in addition to the knee valgus already putting more strain on the ACL, and women often naturally, it's just a naturally occurring thing, the way your bodies are made, it's in your genetics. This, in addition to the knee valgus, the Q angle, all of that is just adding one thing on top of the other, and that leads to the statistic of women being 2 to 10 times more likely to tear their ACL because of these biomechanical differences. So the biomechanical differences and the structural differences lead to neuromuscular differences. So as I mentioned before, females exhibit an imbalanced strength ratio between their quadriceps and their hamstrings. And in addition to this imbalance, females are generally weaker in terms of the ratio in their quads and hamstrings. Not saying that women aren't strong or anything like that, but compared to their bone mass and their body mass as a whole, they're weaker than what males are, if that makes sense. So aside from strength differences, women also experience differences in muscle activation patterns in their hamstrings, their gastrocnemiuses, and their quads than men do. So knee kinematics and neuromuscular changes have, like I said before, have not been completely proven. There have been studies that show, yes, this is the indicator, this is why there's outrageous numbers of women tearing their ACL. However, there have also been studies that say no, there's really not. However, there's still a lot of research. This is a new phenomena, a new issue, so there's still a lot of research that has to be done with this. But what they found is with the knee valgus and everything I explained before about the biomechanics, when women go to perform their squats, their jumps, what happens is their knees bend in instead of like here we have, this is how your squats are supposed to look, nice straight angles, straight 90-degree angles parallel to the floor. But with the knee valgus, squats often look like up here like this. So the knees bend inwards, that's excess strain on the ACL. The knees are crooked and the imbalance of strength, the hips are turned. And these are all factors that women don't even realize that they're doing. They may be think they're doing everything right, however, that's just how they are built, that you'd have to focus and have training to prevent this. The difference in neuromuscular control of the knee joint and flexion of the knee increases the load placed upon the ACL, which also, like I said, causes the ligament to have excess strains and tears. And also the New England Journal of Medicine has an edition specifically on neuromuscular and its impact on neuromuscular connections or differences between male and female, and their impact on the athlete's susceptibility to knee strain. And they found that the increased knee valgus, which as you see here, did in fact lead to increased susceptibility. So yes, that was the conclusion of that study. So, all that being said, once your ACL is torn, what happens? Basically, there's several ways to actually diagnose if your ACL has been torn. You can get an x-ray to analyze the bone and the bigger tissue damage. That'll show if you also, say, broke your bone or whatever, if you had a direct collision, such as in football or something like that. However, once you go to the hospital, the doctor will give you a magnetic resonance image or an MRI, and that provides the doctors with a very detailed image and an idea of what's going on actually inside of the knee. Also, we have ultrasounds, and those can just show softer tissues. Those can help show damage to the muscles or if anything else has been torn or the smaller ligaments within the knee. And so first aid givers that give, such as athletic trainers that would be there to help an athlete who has just torn their ACL, their first concern obviously would be to help with the pain, because this is excruciating. It's very painful when this happens, and the knee will immediately swell up. There will be massive fusion or large swelling within the knee. And then so first aid givers such as athletic trainers, Brian Shapley, actually, athletic trainer here at Palisades High School, said that the ACL's main function is to prevent anterior translation of the tibia under the fixed femur. So we already went over what that means. And so if, say, Brian Shapley, say he suspects that someone has torn their ACL, what he does is he'll perform either the Lachman's test or the anterior drawer test. And these tests test the integrity and the laxity of the knee. So they test basically its looseness. And so what they do, this is the Lachman's test and this is the anterior drawer test, and they will have the athlete lay down and bend their knee, and then the trainer will push down on the femur and pull up on the tibia or the shin. So they're pushing down on the thigh and pulling on the shin. And they will always compare the injured knee to the uninjured knee. And if the injured knee, if they are finding that it's just there's no pull at all, it's no resistance and their tibia is coming forward easily, or if the athlete experiences a lot of pain and their tibia is coming forward, then they know that this athlete has definitely some serious damage to their ligaments within their knee. And then also the anterior drawer test, that's just, you're not pushing down on the femur, the leg is at an increased angle and you pull forward, and if the shin comes out from under the knee, which it's not supposed to do, you know that you have torn your ACL. Yes, so there we go. So there are several treatment options, and it basically depends on your lifestyle. For older patients that live a more relaxed, easier lifestyle, that aren't athletes that are running around every day and jumping around, the doctor might say, you know what, it's not worth it to go through the surgery. It's a lot of recovery, it's a lot of money, and they might just recommend bracing the knee and doing physical therapy. This is also helpful for patients if their ACL hasn't been torn all the way and they don't have a very strenuous lifestyle, they're not athletes, they're not young people. They will just say, you know what, we're going to take you in for physical therapy, and what they will do is they will do exercises to help strengthen the leg muscles and provide more stability to the leg. They will also correct their landing patterns and teach them proper leg movements and how to land and squat and bend over so that they can prevent further injury. However, what has been found is that the surgical option for treating the ACL in the long term is $4,000 less expensive than the non-surgical option. That's just because when you go with the non-surgical option, a ligament will not heal by itself. It needs to be, if it is torn, it needs to be surgically taken out, replaced, surgically put back together. Unlike your tendons and your muscles that do heal by themselves, ligaments are not like that. So they will be like this for life. It will not change. And they will need to have their physical therapy for life. They might even need crutches or help walking for the rest of their life. So, quick going back before we get into the treatment for the surgical options. Early reconstructive surgeries for the knee were deplorable. They really caused more damage than help, and that's just because the technology did not exist for them to really. There were no MRIs in the early 1900s, even the mid 1900s. They didn't have your detailed ultrasounds. They just didn't have it. It wasn't there. So the doctors really kind of had to guess, and oftentimes they, according to Dr. Russell Warren, who has been the New York Giants team physician for the past 30 years, as well as a surgeon at the Hospital for Special Surgery and professor at Cornell Medical College for the past 30 years, said that he's seen it all. He's seen the whole process and the evolution of this. He said that altogether, these injuries would just be missed or not treated. And in fact, during the 1960s and even into the 1970s, it was an ongoing debate within the medical field about whether the ACL was actually needed in the knee for the knee to perform functions and whether to even surgically repair it at all. And they just didn't know. It was not something that they knew of. So, however, Warren's colleague, Dr. John Marshall, who was also a surgeon and a professor in New York at the Hospital for Special Surgeries, he found, he was a veterinarian before he became a surgeon, and he often treated dogs who had torn their ACL, and dogs who caught their leg in a hole or were chasing a rabbit and turned the wrong direction. And he, went along with what was in the medical books, that it didn't have to be treated. And so what he found was years later, when the dogs were older, they were coming back with horrible arthritis in their legs. They couldn't walk. Their knees were horrible. And when he checked his records, he noticed that these are the same dogs that experienced issues in their ACL. And so that inspired him to go to medical school and learn more about this. And with his work with Dr. Warren, who was involved with the New York Giants, and what they found was that athletes as well experienced the same problem as the dogs, and that athletes who had torn their ACL or had this type of injury, they would keep playing. They would slap a brace on, get them out there, they would keep playing. And in a couple of years, they couldn't walk, they could barely stand, they couldn't move their legs. And what happens is the meniscus, which is right there, it's like a shock absorber for your knee, and it keeps your femur from grinding against your tibia. And without the ACL there's nothing to prevent, when the ACL is torn, there's nothing to prevent the tibia from moving around underneath the fibula. And that increased motion, that lack of stability, causes the meniscus to be worn away, and it gets ground down, and eventually there will be little to none left at all. And without that meniscus there, you'll have your bone grinding against your bone, and I can't even begin to put into words how painful that is. So these athletes were coming back with this problem. They had no meniscus, their bones were grinding against each other, they couldn't walk, they had terrible arthritis. And what happened was Dr. Warren and Dr. Marshall put together, they published their findings in the study, and they've got a big grant, and through Cornell and through the hospital's special surgery, they were able to put together and publish several works that revolutionized really the whole treatment of the ACL and proved that yes, this is a big thing that needs to be treated. And their research led to what we have today, which is arthroscopic knee surgery. So I'm sure if any of you guys have seen someone who has gone through an ACL surgery, they usually have a big, if this is their knee, they usually have a big scar running along here and then several smaller holes. And what happens is, in arthroscopic surgery, it's the use of a small camera, and they make minute incisions in the 3 places in the knee, and they have a camera go in, as well as a light source and something to drain out extra fluid, which is there because of the swelling and the cuts and whatnot. And so they use the camera, and then they also insert the arthroscopic instrument, and that instrument just goes in and they are able to repair the knee through that and using small drills and minimally invasive surgery. Grafts, tissue grafts, are most often used in repairing an ACL. That's because, like I said before, ligaments do not heal on their own. So what they do is they will go in and they will cut out the injured ACL, they'll cut it off, and then they will take a tissue graft either from, they can take it from a cadaver most often, someone who has donated their body to science, they will take it from there. Another place they can do is from your patellar tendon, which is on your kneecap. The patellar tendon just runs right over top, and because that's a tendon, it will regenerate and it will heal by itself. So they can take a piece of that and they can put it in, and they can also take tendons from the back of your leg and up in your hamstring to replace that. So, got a quick video of an arthroscopic surgery.
Your knee has 4 major ligaments. The knee ligament, called the anterior cruciate ligament, or ACL, connects the thigh bone or femur to the shin bone or tibia. An ACL that is severely torn may be surgically reconstructed with a graft, so that your thigh and shin bones are connected with ligaments or tendons taken from another part of your leg. To do the procedure, the torn ACL is removed and the graft is attached through holes the surgeon drills in the thigh bone and shin bone. After the graft is passed through the holes, it is held in place with screws or other devices. Incisions in your skin are closed with stitches, tape, or staples.
Alright, so an estimated 4 million knee surgeries like this are performed each year, and according to the Academy of Orthopedic Surgeons, and also according to the Academy of Orthopedic Surgeons, roughly $850 million are spent annually on these type of knee reconstructions, which in the long term are $4,000 less expensive than the non-surgical treatment, because what happens is you go through, you get the operation, and then through after the recovery in 9 months, then you're good as new. According to Brian Shapley, the athletic trainer here with Coordinated Health, he said that generally all athletes are able to, if they go through their physical therapy, they do the proper exercises, and they really work hard, they can fully recover and return to their full performance that they were at before they tore their ACL. So this arthroscopic surgery, in the future, really the opportunities are endless for what this surgery could develop into. I mean, now we went from having athletes that were really just permanently disabled from the surgery and from non-treatment in the past to today with this minimally invasive surgery that is done with tiny little drills and cameras. I mean, to be honest, I have no idea what the future could hold. The opportunities are endless. Today, their pioneers are going through with lasers even to go in and help fix this, and I'm sure that as surgery continues to advance, the incisions will get smaller and the recovery time will decrease as well. But also in the future, I believe that there will be better opportunities for prevention of the ACL, so that people don't even have to get these surgeries anyway. I know that, say in the NFL and D1 college athletes in football, they're designing braces so that when they're prone in this position, there's braces designed that they wear when they're playing so that when they are hit or tackled, it doesn't, the braces give their knee stability and their shin doesn't pop out, their leg doesn't move, it doesn't twist, and they just won't tear their ACL because they'll have this extra brace. So, quick, we also have an interview. This is an interview that I conducted with a member of my soccer team actually, and she just got back from tearing her ACL. Well, we'll watch the video and I'll explain it.
How did you tear your ACL?
A girl took my leg out from behind me.
Okay.
It wasn't like a start-stop, it was like she just came up behind me and kicked my leg.
Okay,
Right
and
behind me.
did the bottom of your leg go forward?
I felt my shin pop out.
Your shin popped out?
Yep.
Okay. And what was your rehab like?
Oh god. It was fun because it was like, I knew I was getting back into it, but it was like, you had to start with a bike. I couldn't walk. So I had to be like lifted over to a bike, and I'm trying to ride a bike, and then eventually I got to the treadmill. Probably the scariest thing was getting on the treadmill.
Why?
I haven't ran in like 4 months, and then you get on a treadmill and you're like, oh crap, I gotta run.
How'd they do that?
There's this like machine that's like this high, and you have to like practice like jumping off of it and landing perfectly. and you do ski jumps in front of a mirror.
What was different about how you had to land before and after?
Well, like, my knees naturally go in, so I had to, like, purposely turn my knees out and, like, adjust my body with my core.
Okay. And how long did it take the whole process before you're fully 100% back?
The full process, like, being back on the field and, like, still, like, learning with my brace, it probably took, like, 8 months, but rehab itself was 5.5 months.
How long did you have to wear the brace for?
I wore it for 7 months.
Alright.
So as you heard her say in the video, what happened was she felt another player came up and kicked her leg out from behind her shin popped forward, and her ACL was torn. In rehab, they told her that her knees had valgus and they naturally turned in, and what she had to do was practice jumping and landing correctly in front of a mirror. She had to completely relearn. She was a little camera shy, so afterwards she told me, she filled me in more. She had to completely relearn walking really after her surgery. She also had to completely relearn changing direction, pivoting, jumping, landing. And she said that the whole process really was very long, and she said that it was hard to relearn because like it's something that you do naturally, and she just had to completely change what she was doing. So there are several ways that prevention has been implemented and will continue to be implemented. Excuse me. And basically it comes down to neuromuscular training, which is, all of you have heard that are athletes in here, muscle memory. And what that is practice. You practice again, and eventually you don't even have to think and you just do it. But when you get to the point where you're not even thinking, and you're continually doing this, as your body changes, especially for females going through puberty, their hips get wider, their knee valgus increases. When you used to be able to, when you were younger, just quick change directions, next thing you know, you have something like this, where you change directions and you twist and your ACL is torn, and there's no one even around you to tear your ACL. So there's the prevention techniques that are used. There's balance, strength, and technique itself, and basically they just teach balance in the stabilizing your muscles, and they work with that. Strength, they strengthen the muscles that are surrounding your leg to help combat the elasticity that women have from the extra hormones. And technique is the neuromuscular training part, and that's the core aspect of it. So in this picture is just one of the ways that we have for preventing, and that's just like the ski jumps, you jump side to side, and that will help with the lateral strength. And then also I've got some actual examples over here, so I would like a volunteer to try them out for me. I would like to give that a try. I can't do it. It does require...
I'll do it.
Alright, go for it. Alright, so over here we have... I'll hold it up so everyone can see. This is called a Bosu ball. And this is from a physical therapy thing, so come on, don't be shy. And there's several ways you can do it. You can stand on the squishy side, or you can stand on this side, so stand on it. And, yep, both your legs, and then you just stand on that, and then you squat. So place your legs far apart.
Trying to kill me up here. Not squat down.
Yeah.
Oh man, I'm flat.
Yes. So, very good. There you go. All right, you can get off.
I'm gonna tear my ACL doing that.
So there's that, and then also on the other side, I'm not going to make you do this because it's very hard. There's one-legged squats that you can do with this, and then what they'll do eventually is they'll add on weights to that. So you're doing that with weights to also help with your strength training. Also, we have these balance boards for everyone to see. You have your 2-peg one and then your single one. What?
Love those.
Yes, and we actually use these. We've incorporated these into the soccer program here at Palisades to help with the team itself prevent their tears. So you can stand on this and squat again. And with this, there's several ways you can do it. You can do it that way. Yeah, that's fine.
Try to balance in the middle.
Yeah, you balance it so that it's perfectly balanced, and then squat when you get it balanced.
I think we chose the wrong demonstrator. I'm not very good at balance.
Yeah.
I think it's easy with
I can't even do the Wii thing where you balance.
I'm surprised you can do the ball and not that one. You did good on the ball.
Yeah.
Like this.
That's actually a different exercise for it. So there's different ways that you do it, and so yeah, it really, it's a workout. It's a workout.
Does this mean I'm gonna tear my ACL?
No.
If I can't balance on it.
No, you're fine. But yeah, and then, so there's also one with just one, so this would be turning all different directions. This one's only 2 planes that you're moving in. This one you have 360 degrees to work with. And what you will get to is one-legged with weights, and you want to get to the point where you can balance it flat and squat on it. And use the top. Thank you, Tanner. Yes. So yeah, the whole purpose of that is to teach proper squatting technique as well as develop the muscles and your neuromuscular transitions. So, as I said before, advancement in medical and rehabilitation techniques have improved the diagnosis, treatment, and recovery of cruciate ligament injuries. However, there is still a great disparity between male and female susceptibility to cruciate ligament injury due to structural, biomechanical, and neuromuscular factors. Thank you guys all for coming. Does anyone have any questions?
First of all, round of applause.
Thanks. Yeah, I was watching the clock. I was getting kind of nervous, actually.
For those of you who are filling out the rubric, I'm just going to remind you that you can circle different parts of the rubric, okay? So it doesn't have to be all in one box, because people don't live in boxes. And then she was spot on with her timing, okay? So it was perfect timing that way. Before we do that, however, what questions do you have for our distinguished presenter?
So I think maybe you touched on this a little bit when you were talking about puberty and how it happens after puberty, but my question was just like, is there like a specific or like certain age that women are most like likely to?
Well, that's part of the reason that the studies are kind of, some of them show up inconclusive.
Okay, yeah.
Because there's no set time, like on your 13th birthday, you've hit puberty and your hips are suddenly like this. Like, no, it's gradual and everyone changes, everyone hits it at different times. So yeah, it's different for everyone, really. So.
Do you think now that like we're more aware of like these things, like we can we will be able to prevent it more? Because like some of those things you were saying, like just like our body type, it's not like that's gonna change. Like in the beginning, I was like thinking like we're just like women are doomed, like you know what I mean? Like there's nothing we can do about it. But
I definitely do, because well, one of the things I found, actually, this is like part of the past that I talked about in my paper, was when Title IX was passed, women really began to start, like from that point, which was in 1972. Like before then, women weren't really involved in sports, but after that, they got like a lot more into it. And as like today, like women play sports all the time, like it's like a thing. And now it's more common, and people are like paying more attention to it. And I do think that it will improve the prevention. Well, like you can't change the way you're built, but I know like universities and stuff, like it's part of their weight training program now. Like your training is like they train this; it's part of your workout.
Has ACL injuries become more common, or is it just like people are like aware about it more now?
People are more aware. More aware of it. Mike.
I know that not everybody, when they walk, their foot is like perfectly straight. Their foot will sometimes slant inward or outward, and because of that, they can then change their ankle and the slant of their hip or of their shin bone. Could that cause more susceptibility to an ACL injury as well, or?
The slant of their shin bone?
Yeah, from like their foot not being straight when they walk.
I mean, it could. I didn't really come across that directly outlined in my research. But I would say definitely if your foot's slanted, especially if you're running and you go to change direction and your foot slants, then your whole leg's going to shift. I would say definitely. Mom?
Your research, you stated that Palisades has incorporated prevention measures.
Yeah.
Has there been a direct correlation with the new exercise program to the injury rate that happens in our girls' soccer team?
I mean, I know that our girls' soccer team, I think that I can't really make that generalization right now. I think that we need to make it more, have more people coming out and have it implemented for a couple more years before we can officially say that. It's a pretty new program, so I would say not yet. But eventually, hopefully, yes. Tim.
Sorry.
After if you've torn your ACL and had the surgery and you got like the graft thing, after you completely recover, are you more likely to tear it again or less likely?
No, good question. Actually, I found this in my research, and also Brian Shapley also stated that your ACL that's reconstructed, is actually stronger than the one that you're naturally born with. Kathy?
when they use like cadaver ones, do they only use like male ACLs so they're like stronger?
That's a good question. I don't know. I would assume maybe. I don't know. I'll have to look that up. Yeah, I don't know. I don't know what gender.
No, she can go because she didn't ask me.
You said it's more of like a new topic. Does that have to do with like the lack of knowledge in the past, or that women like didn't used to play sports as much as they?
It's a combination.
Okay, here's the second question. I don't know if you came across this, but are like professional athletes or college athletes or like high school athletes more common, or like do they tear their ACLs? Like which group like gets these injuries like most? Like,
If I would have to say, I would say it's high school, because generally there's more, like the ratio of people to athletes is higher in high school. Like more people do high school sports, and then people when they get to college they don't play anymore, and then even fewer people like after college, like most people don't go pro. And also at the level, especially like D1 and pro, it's they're getting like working directly with the professors like John Marshall and Russell Warren. Like they bring them in and they sit down at a table and they design their weight room stuff because at that level they're so like meticulous about it. I would say high school is more common.
Okay. Well, after Tanner stole my question.
like I mean, I'm probably not ever really heard of this, but like, is it common for someone to be able to like stand up after they tore their ACL and not really experience, like not really know right away that they just tore it, or is it just so?
It's very,
like,
from the
so
people I've
painful.
talked to that have torn their ACL and have gone through it, from the people I've seen tear their ACL, and also from the doctors and trainers that I've talked to, they said that it like, they usually know that there's something really wrong with their leg.
Some injuries, like you don't notice it right away.
Yeah.
But, okay.
Yeah, they said they usually know right away. I mean, they said that it's just like an excruciating pain, and they also said that they can feel it if they try to walk or something, like if they have adrenaline in them because they're in a game and they don't feel the pain right away. They said even if they try to walk, it feels like they're standing on a marble and their legs just moving around. So yeah, they notice pretty quickly.
Have you seen any data in regards to the other knee having an ACL injury shortly thereafter, their rehab of their original injury?
Yeah, there were studies about that, but when I looked into that in my research, and they were very contradictory. In the research I found, some were inconclusive, some were saying yes, some were saying no. It was very hard to make a generalization about that and summarize it. It basically, what I found is it basically just depends on how seriously the athlete or whoever takes their rehab, and like how seriously like they actually focus and take like relearning the techniques.
The other question, everybody asked all my questions, that's perfect. You talked about technique. I'm just curious, are trainers available when you are in the weight room to show you proper technique, or do they check on your technique?
They should be. I mean, I can't say that they're there all the time, but coaches, there's increasingly, as it's becoming like a bigger issue, coaches and stuff, they're going to workshops and stuff to help them with that. And then, I mean, coaches should be in the weight room with their team anyway to just make sure that no one gets hurt. But yeah, I think that there should be, if you have questions, there should be people to go to, yes.
Are animals also getting the same type of technology benefits from this data to help them with their rehab, or was the dog research being used to help the humans, or is humans being used to help the dogs recover?
Well, for my project, I didn't really focus on the animals, but what I found when I looked into that study was that the dog research was help the humans.
As someone who's like I know you've been like going to like soccer tournaments and stuff and like looking at different colleges, have you ever, when you talk to like a college coach, did they ever say anything to you about like, oh, make sure your ACLs are okay, or have you ever torn your ACL?
I've never torn my ACL, knock on wood. I've never torn my ACL, and No, I mean, there's athletes, there's all kinds of stories, like girls that have torn their ACL and then still manage to come back and get into schools and play at schools, and then there's also girls that made it through their whole entire career without tearing an ACL, and then their first game of their college, they tear it and lose their scholarship. So it depends on the program. I would say it depends on the program. But yeah.
What was the most useful resource of all of your multiple resources?
Most useful resource? Probably the Academy for Orthopedic Surgeons website. I would say it was really simple and easy to follow, and then it also gave me, like, it was where I started off my research, and it gave me most of the diagrams I used in here actually are from there, and they also gave me, like, I was like, oh, that's interesting, like, I need to look into this more. Like, they outlined everything and gave me a lot of general information that I didn't know and that I needed to know, and also let me, like, it gave me really a guide and where I need to look further into for the rest of my project.
Excellent.
Yeah. All right. Thank you all for listening.
Thank you.
Do you want my notes?
Yes, I'll take them.
Just kidding.